Welcome, Anthony. How you doing?
Good. How are you?
I'm doing good. So we're going to talk today a little bit more about diagnostics. So we've been doing this now for almost 2 years, I think. I started a training process about 3 years ago, and really this is for us to be on the cutting edge of physical therapy. Adding in diagnostics is something really that not a lot of clinics are doing, but it's been awesome. Don't you agree?
Yeah, it's been eye-opening, and I wish we would have done this a lot sooner.
Yeah, me too, definitely. So let's kind of split them up because there's two different things that we're doing. One of them is we're doing MSK ultrasound, and then the other thing we're doing is EMGs, NCS. So let's talk a little bit about the MSK ultrasound. So MSK stands for musculoskeletal and an ultrasound. It's the same type of ultrasound that is used to diagnose, look at pregnant women, make sure the baby's healthy, look at your gallbladder and things like that. But then we're using it to look at tendons, bursas, ligaments, and everything, right? So you've been doing this now for quite a while. So what's some of the stuff that you're looking for when you do this?
So basically, we will use it mostly for the extremity, although you can argue that you can do it for some spine, but very, very limited. So if we're talking extremities, we can assess ligaments. Someone comes in with a ligamentous injury, we can scan it. We as PTs rely on certain tests and measures that you learn in school to push this way or move the joint this way to get an answer about which ligament is involved or ligaments are involved. So we still do that, however, with more depth, because now we can take a picture of the inside. We can look at that ligament, whatever it is that you're testing, take a picture right then and there, and use it to help us confirm our PT diagnosis. So very versatile.
Yeah. So, and a little bit more accurate than the special tests that we do in physical therapy, because we know they're pretty good, but they're not super accurate, right?
Yeah. If you look at how much the percentages go up when you combine the basic PT special test with a MSK ultrasound, it goes much higher.
Yeah, definitely. So that means we have more certainty that what we're doing is going to actually help the problem, because we now really know what the problem is.
Yeah, you know exactly. Hey, my shoulder patient isn't getting better. You take a picture of what's going on. Well, yeah, they have a pretty significant tear. So rather than spinning our wheels in the mud, providing a treatment that we know we're probably not going to get better after a certain amount of visits already. Well, now we know why.
Yeah. So it helps us be better in our treatment, but it also is better in knowing when not to treat, or when physical therapy is not going to help somebody and maybe they need to look at surgery, right?
Yeah, as PTs, we're trained to, not exactly, I don't want to say we're trained to, but we come into the field as conservative as possible. Conservative meaning we want to rehab the body with the least invasive procedure possible. And when we're making small gains, we still justify that as we need to continue. If you exercise someone, regardless, they're probably going to get better anyways. And we use that to just further the need. But sometimes, even though someone's making a little bit of progress, we still aren't providing the quality care that we should be providing, because we're missing something if they're not getting better as they should be. So the diagnostics allows us to see why they might not be getting better. Most importantly, if you do it early on, you know what you're going into right off the bat, rather than doing a couple of visits, reassessing. Why isn't my patient getting better? Oh, this is why. You have that information up front. So number one, you understand the anatomy of the injured anatomy, number one. And number two, you're not spinning your wheels after 2-3 months of PT trying to get someone better and holding on to the fact that they've made small gains as a means to justify another month on top of the 3 you might have already had.
So it kind of compared a little bit with like x-rays and MRI. So obviously if you think you've broken a bone, you probably need an x-ray, or if the doctor thinks that you've broken a bone, you probably need an x-ray. But other than that, x-rays aren't all that useful. It may show a little bit of arthritis on there, but in general it's not the greatest test other than for fractures, right? So let's compare it to an MRI, because a lot of times, depending on the structure that you're looking at, an MRI and an ultrasound, they're kind of looking at the same thing, right?
Yeah, they are. They're looking at structures. They're looking at muscles, tendons, the joints. They call it the gold standard for a reason. But there's a big difference between, setting yourself up for an MRI versus an ultrasound.
Yeah, definitely. So let's talk a little bit about that. MRI, costly,
Yep.
right?
Very.
I don't know, a lot of times I hear $1,500 or something like that. So that's a pretty expensive test. You need to lay still in a tube. So if you're claustrophobic, good luck. And even the open MRI isn't as open as you thought it was going to be. So you have to lay still, which isn't that easy for everybody. And it cannot be done on everybody, right? Because if you have a pacemaker or if you have a metal implant or something like that, you can't have an MRI. Now let's look at the ultrasound. Ultrasound can be done on anybody, including on pregnant women.
Yeah.
Where you can't have x-rays, you don't want to do an MRI if you're pregnant, but ultrasound, well, we've been doing that for decades. So it must be safe, right? And it is. So we can do this on anybody. It's a cheap test. You're done with, maybe a couple of $100 at most. It's done in about maybe, 15 to 30 minutes, kind of depending on what we're looking at. You can do it in a very comfortable position. And if you move, that's okay. Actually, sometimes that's the nice thing, right? You need to move because, laying in an MRI, you're laying down, you're not moving, well, things don't hurt as much. I see it was like, well, I'm moving my arm, oh, and there it hurts. Well, with an MRI, you can't look at that. But with the MSK ultrasound, you can look at it and you can see exactly what's happening. Right? You want to give us some examples of what you've seen?
Yeah. So to that point exactly, let's take the shoulder for example. One of the more common conditions we see is the shoulder impingement syndrome, which is one of the muscles is getting pinched between two bones in your shoulder. So the one way it hurts is when you move your shoulder. So when you raise your shoulder, that's how you create the impingement. Well, in an MRI, your arms are to your side and you're not moving. So you're not going to see the shoulder impingement happening because your arms are by your side. And the way to recreate the impingement is through motion and lifting your arm up. So one of the great things about ultrasound is you can have them do just that. I'll put the probe over their shoulder, they raise their shoulder, and I can look at the mechanics and see the actual impingement. And the best part is I can show the patient where the impingement is happening. You can't do that with an MRI,
Yeah, not at all. Not at all. So really that's a nice thing. And I think what I like about the MSK ultrasound too is a patient can see it, right? We can point it on a screen, they're looking at it. With an MRI, you have the MRI done and you get your results in a couple of days or sometimes a week or so, but you don't really see it. Well, we can show a patient exactly. They may not know what all the different colors of gray are, but we can definitely show them like, hey, you see this is what's happening, or hey, you see this tear, this is not supposed to be like that. And a lot of times we can easily compare left and right. MRI, you're only going to have an MRI of the right shoulder, so we don't know what your normal is. So I think it's a great technology that's really going to replace at least some of the MRIs. Not all of them. It can't look inside joints, so if there's anything inside a joint, inside your shoulder joint, or inside your hip or knee, we can't really see that. But definitely on the outside, we can see a lot.
Yeah, it can definitely serve as a screening tool also. If we see something that's obviously impaired, then we'll recommend the MRI. But at least we know beforehand.
Yeah.
Because a lot of the times there is nothing there. And a lot of the times PT is successful with rehab and the person never needed an MRI to begin with. So the ultrasound is a good way to, provide that conservative treatment, that conservative method that PTs go for.
Yeah. So you can do an ultrasound and several weeks of physical therapy by the time you've paid for that MRI.
Yeah.
And an MRI has never, cured anybody, right?
Yeah, exactly. I digress on MRIs. Sometimes they're really great tools, but sometimes it creates a negative picture that sometimes doesn't have anything to do with the actual pain onset either. But that's a conversation for another day.
Yeah. We'll have that another day. So definitely for anybody that's out there that has had some sort of an injury to a tendon, a ligament, a bursa, if you have hip pain, shoulder pain, things like that, absolutely come see us and let's take a look at that and see what has happened to the structure and what's happening when you're moving. Good. So now let's move on to the other part of the diagnostics. That's even a level up, I think, from the MSK ultrasound, and that's EMG NCS. So what does it stand for, Anthony?
Nerve conduction velocity testing,
And electromyography.
electromyography.
So it's really looking at how the nerve and the muscle function. You're pretty much always going to do both, right? You're going to do both, looking at the nerve itself and then looking at how the muscle is being influenced.
Right. So the way I explain it to patients is the first test we're going to do, the NCV, the nerve conduction velocity testing, is we use a small little stimulation and we stim where the nerve runs. So we stim the nerve. So we put a recording, we put a little electrode over one part of the muscle or one part of the body, or on the other end of the nerve, I should say, and we stim at the other end, and we basically send a signal and we catch it, we record it, and we test to see how fast it's traveling down the nerve. And that's a great assessment for the health of the nerve. The second part is we use a small little pin. Sometimes I say pin, sometimes I say needle, it just depends what I get from the patient, but it's not even worthy of being a needle if you look at this thing. It's a very small, very thin needle, and we have to place that needle and sample muscles. And that's important because you want to see the electrical activity of the muscle. So you combine speed of the nerve with electrical activity of the muscle, and that gives you a great test that we as healthcare providers definitely use.
Yeah, just to see if there's something wrong with that neuromuscular system, right? Because muscles can only work because of a nerve signal, traveling to it. Muscles don't do anything by themselves. So this really helps us to evaluate, if there's a problem with the nervous system and how it leads up to the muscles, or maybe not. Let's talk a little bit about the most common diagnosis that we're probably going to see for this, right? Carpal tunnel syndrome?
Yeah, I would probably say carpal tunnel syndrome, and really close behind that could be cervical radiculopathy. And these two, it's kind of funny how they almost blend together as far as symptom presentation. Stopping short of this lecture being like this, PT lecture, for those listening, if someone has carpal tunnel syndrome, you can have numbness tingling in their hands. If someone has radiculopathy, which is coming from the neck, cervical radiculopathy, I should say, you can have numbness and tingling coming from the hands.
Yeah, so
which is it?
Yeah, they have both the same symptoms, but a little bit of a different treatment protocol, right? Because for a carpal tunnel, maybe physical therapy will work, maybe not, maybe you need surgery, but then the surgery would be on the hand, on the wrist. If it's coming from your neck, physical therapy may work, you may need surgery, but the surgery would be at the neck. And you sure do not want to, you probably don't want to treat, in physical therapy, the wrong body part, but definitely not in surgery. You do not want to, do surgery on the wrong body part. Have neck surgery and it's a carpal tunnel, or have carpal tunnel, surgery and it really was coming from the neck. So it's very crucial that we find out where those symptoms are coming from, and really the only way to truly do that is with EMG NCS, right?
Right, yeah. The special testing itself isn't very conclusive. I've seen a lot of true carpal tunnel patients come in with negative Tinels, so like wrist tapping, and negative phalens, so bending the wrist, which don't create symptoms on a person who does have carpal tunnel syndrome. On the other, going up to the neck now, I've seen where you do what you call Sperling's test. You bend your head off to the side and you push down a little bit. Usually doesn't reproduce symptoms either. So as a physical therapist treating this patient, if they're referred for neck, you kind of stick with the neck. If they're referred for the wrist and carpal tunnel, you kind of stick with the wrist, but all the while knowing this could be something else.
Yeah.
Yeah, and the greatest thing about the EMG is you can figure out exactly where it's coming from.
Yep, and then you can treat the right body part, whether it's with physical therapy or with surgery. And just to kind of highlight a little bit on the carpal tunnel, because carpal tunnel, very common condition, happens a lot, especially with all of us being on our phones and iPads and doing data entry and all of that. So very common condition. So this happens a lot. How do we know whether somebody needs surgery or if maybe physical therapy is going to be good enough? How can you determine that with an EMG?
So with the EMG, you're going to see definitely differences when you use the needle part. So when you do the EMG and you stick it in a certain muscle in the thumb, the screen will light up. You'll see certain abnormalities that you're not supposed to see. And when you see those things, you know that, hey, this is probably one of those cases that I'm not going to start and initiate a month of therapy. This is probably something I want to send to the doctor and let them know, hey, there's what we call axon damage. Axon is basically, like if you think of a wire that goes from the light switch to the light, the axon is the copper wire. So you know a wire, right? Picture a wire. There's a rubber tubing or rubber coating surrounding the copper, right? So the copper itself is the axon. And if there's damage at the axon, you probably need to go back to see your doctor, because that's not something you can just fix randomly if there's axon damage. Now, if there's myelin damage, so going back to the wire example, the rubber coating. So the myelin is what the nerve uses to send messages down faster. So if there is a myelin problem, that is something you can rehab for sure. And there's techniques, nerve lights, stuff like that you can use. But you got to be sure. You got to be sure if you're dealing with a myelin-ish injury or dealing with an axon injury, because there are two different things that will offer two different results if you're wrong.
Yeah. So definitely, if it's axon damage, have surgery. Don't wait. Don't waste time. Whether you're just waiting in general or even waiting in therapy, because it's not gonna work. But also, there's going to be more nerve damage, right?
Yeah.
So if it's only the myelin, it's probably safe to say physical therapy should help. Try the physical therapy, your symptoms probably will go away. Now, so without the EMG or an NCV, NCS, how would somebody know? Is there a difference in the symptoms between axon damage and myelin damage, or not really?
I think the biggest key indicator as far as differences would be if you look at your palm and you look at the muscle, like at the base of your thumb. If you see it like disappearing, that would probably be the biggest indicator that there is something axonal going on. Otherwise, you can't really tell.
Yeah.
Otherwise, it's the same. And when you see the muscle wasting, that is a pretty extreme case. That is something that's been there for a while and hasn't had any treatment, and now because of that, your muscle is disappearing. But otherwise, if you exclude that extreme case, you might not really know. You can't see it.
Yeah. They all have probably some numbness, some tingling, and all going to complain maybe of some weakness in the muscles.
Yeah.
And that doesn't matter what it's coming from, right?
Yeah, and you still don't know where it's coming from. Like I said, if we take cervical radiculopathy versus carpal tunnel, their symptoms mesh and blend together. On certain cases with carpal tunnel, someone will have, if you look it up, Google will tell you, or any anatomist or whoever will tell you that the median nerve will innervate the first, the second, the third, and part of the fourth finger. If someone has carpal tunnel, they usually always say the whole hand is numb. So you never really know. And plus, not only that, people will feel symptoms radiate from their wrist up to their elbow. And that can be confused with symptoms that radiate from the arm down in the cases of cervical radic. So it's really hard to tell exactly what is causing what. Yeah.
So that's why you do this testing, and it'll differentiate between the two. And once in a while, we may see something that's even different, right? It could be coming from maybe a polyneuropathy where multiple nerves or all nerves are being affected. And at that point, carpal tunnel release is not going to help, or neck surgery is not going to help.
Yeah. And I have seen a couple of examples of this in the past where, someone has numbness and tingling in their hands, bilateral hands. Okay, you start to think, yeah, that's not uncommon to have bilateral carpal tunnel syndrome in both hands. And then I ask, hey, do you feel any of this numbness tingling in your feet? And they say, yes. Well, the referral was for carpal tunnel. Well, a polyneuropathy involves all four limbs, that usually symptoms are described as numbness and tingling in all four limbs. So what exactly are we dealing with here? Is it true carpal tunnel, or is it something more systemic?
Definitely helps to, come up with the appropriate treatment, because the treatment for a polyneuropathy is totally different than carpal tunnel, syndrome or cervical radiculopathy.
Yeah, sometimes, the polyneuropathy is undiagnosed. It's not in thought. It's not circulating as an issue. Patient might not realize it themselves either.
Yeah.
It's caught through the diagnostics suddenly when they come in because their hands are tingling and they're like, oh yeah, my feet's tingling too. So that's how, and you have to treat that medically. It's medical treatment for that. We need to get into the doctor for appropriate, diagnosing and appropriate treatment. But you can still do physical therapy, no doubt, after they've cleared with the doctor and you find out what's going on and how it's going to be processed and so on and so forth.
Awesome. Well, so it's been definitely an adventure for us to be into training, because this takes a lot of extra training beyond our normal physical therapy training that's already been pretty intense. But I also feel that we're really on the cutting edge of physical therapy, right? I think this is really where the physical therapy field is going, just expanding what we can offer to our patients.
It definitely allows a therapist to be more accurate with their prognosis, with their plan of care. I mean, right? That's the goal. You do all these tests and measures, and each of these tests and measures has a percentage of accuracy, for simplicity here. How good are they? How good are they not? Do all 6 of these tests, for example, and then make up your mind, essentially. The diagnostics totally opens the door to a new front, a new era, I would like to say, of accurate testing, that if you can deliver the most accurate testing and results, you can deliver the best plan of care.
Yeah, absolutely. So, all right. Well, thanks, Anthony. It was good talking to you about our diagnostics, and if you have any kind of problems out there, come see us. We'll help you.
Thank you.